metrics for which we are on track and metrics for which we have some work to do. We're on target in peer-delivered services. We have peer-delivered services in all 36 counties in the state. We've provided peer-delivered services to over 3,500 individuals in the past year. Our focus in the regional behavioral health collaborative in the Portland area is peer-delivered services related to substance use disorder treatment as a way to try to provide more access to treatment more quickly to be able to deal with people when they're in a treatable moment. In SUD, this is a very positive spot for us. Mobile crisis is available in 35 out of 36 counties. We've provided standardized response times by region. Again, mobile crisis has met the needs of nearly 7,000 individuals across the state in the past year. You know, and it's the idea of how do we provide crisis services in the community rather than requiring someone who's in crisis to be sent to the state hospital or some other kind of facility. How do we deal with them where they are, not breaking the link to their housing, which we talked about earlier, those kinds of issues. The last area is supported employment programs. We have 33 supported employment teams around the state, and we serve over 1,700 individuals with those services. Excuse me. Some of the areas that were challenged, a number of state hospital metrics related to patients who are there on a civil commitment as distinguished from people who are there because they're unable to aid and assist in their trial, or people who are there because they're guilty except for insanity and under control of the Psychiatric Security Review Board. Our targets include the percentage of patients who are discharged within 120 days from admission and within 30 days from being placed on the ready to transition list. The progress in this area has been relatively stagnant. And it's a challenge born largely of the need, which is part of what's in the governor's budget and other investments we're making to provide more community-based step-down services and treatment environments to be able to move people from the hospital when they're ready to move. The goals, however, also get incredibly aggressive. We've got we're now moving to a 25-day goal from the time someone's ready to be discharged to be able to be moved out with adequate care coordination, the ability to match someone up with an appropriate service site, all those kinds of things. That's what I would describe as an aspirational goal. If we don't meet that target, the independent consultant that is on contract with us and US DOJ will evaluate us for basically making substantial efforts and determine whether we have systems in place to continue making progress even if we haven't met the benchmark at the end of the US DOJ period. A couple of other issues, I won't call out every single thing, but supported housing and rental assistance is an area where, despite the positive comments from Director Salazar, we're challenged, and really it's a function of rents and the ability of our rental assistance program to keep up with escalating rents. Now, you know, the latest word in the market is that maybe is beginning to level out a little bit, so we may be able to make some more progress. We've been working to repurpose some of those dollars in some other ways to try to get some of the same objectives, but that's an area where we're not currently on target. So let me talk for a minute about, or maybe more than a minute, about residential facilities. Secure residential treatment beds are critical in helping place those who are at the hospital and ready to move from the hospital into a community. It's also important in terms of kind of thinking of a pipeline in terms of acuity. As people move down in acuity, we want to move them out of that hospital level of treatment, or if they're in a secure residential facility, out of that facility to a lower level of treatment so that they're in the least restrictive environment that provides the best treatment. It's important to do from what's the appropriate level of care and respect for the individual's civil rights. It's also important to do from a Medicaid standpoint, because Medicaid will only pay for the level of treatment that's determined to be medically necessary. If someone's in an SRTF and that level of care is not medically necessary, then they won't pay for that treatment, and that's important.